Cardiovascular disease is the number one killer of both men and women. However, women with coronary artery disease report poorer clinical outcomes and patient experience compared to their male counterparts. Women might attribute some of their symptoms to other causes, such as extreme fatigue, rather than a real cardiovascular event. And women, being caregivers, often put their health last. Our next guest expert wants to change this by focusing her efforts and studies in the realm of women's cardiovascular disease by establishing the first truly dedicated program to care for women with and at risk for heart disease. Health, wellness, career, family, life, and the better side of 50. I'm your host, Michelle Folan, and this is Asking for a Friend. Welcome, listeners. Our guest expert today is Dr. Odayme Quesada. She is the medical director of the groundbreaking Women's Heart Center at the Christ Hospital in Cincinnati. After her graduation from the Yale University School of Medicine and residency at the University of California in San Francisco, Dr. Quesada served as a fellow in cardiovascular medicine at Cedars-Sinai Medical Center in Los Angeles, where she completed an NIH research fellowship in cardiovascular disease in women. She has won many awards in her career and was recently named the Healthcare Hero of the Year by the Cincinnati Business Courier. Welcome, Dr. Quesada.
Thank you for having me. Very excited to be here.
I knew I had to get an expert in cardiology on the show just because cardiovascular disease is the number one killer of women. And this is a very important topic. I've done a topic about cancer, and I really wanted to focus on this. Why is this such an awful disease for women?
Yeah, the reality is that is not actually widely recognized is that heart disease unfortunately remains the number one cause of death in both men and women. And something that I think we want to dive deeper into during this podcast is, what are the differences between heart disease in men and women? Because there are a lot of important differences that we are recognizing and learning through research that we want to share with everyone listening.
Okay. There are other factors. So we have family history as a big factor, but there's also lifestyle. There are the whys behind that. What do we need to be doing in regard to family history?
So risk factors include family history, but it goes up beyond that. So when we talk about traditional risk factors for heart disease, these are the ones that many people recognize: the high blood pressure, hypertension, diabetes, high cholesterol, smoking, of course. That's one of the biggest risk factors that if we make changes could really mean a lot in terms of decreasing risk. And then there's family history, right? So family history is when you have family members, especially if they have heart disease at an early age, which is usually less than 55, when we are concerned, especially if they've had a heart attack at a young age, we want to know about that because that means that the son or daughter of that person is at a higher risk from a genetics perspective. There are also risk factors that are actually more specific to women, and those are the ones that many times are missed and that we're now starting to learn a lot more about. And that includes pregnancy-related risk factors like preeclampsia, preterm delivery, small for gestational age, gestational diabetes. So all these things that before we thought were just related to pregnancy, and once a woman gave birth, that's it, that disease process ended. Now we're learning that that's not true. It's actually recognized as a cardiovascular risk modifier. And then the other ones that are important are things like menopause. Again, more specific to women, only happens in women. Pregnancy and menopause only happen in women. And then there are other things like stress, depression, more common in women, or rheumatologic diseases. Again, these are in both, but more common in women and recognized as risk factors. Lack of physical activity, again, a risk factor for both men and women, but there's actually good data that showed that increasing physical activity actually has a higher benefit in women than it does in men. So I really push women to exercise. And I just published a study in the European Heart Journal on Prevention that showed that women, if they're overweight or obese, they are actually protected from increased cardiovascular risk to some degree and to a large degree if they're physically active, which again talks about what the literature shows when we look at how does physical activity decrease someone's risk. So that's critical.
Okay. And estrogen is cardioprotective?
So the thought is that when women before menopause, women have these protective hormones, predominantly estrogen. When they go through the menopause transition, there's that loss of that hormone, and we see an increase in the risk of women's disease, particularly as they transition. But again, women, if they smoke, if they have high blood pressure, diabetes, all these other risk factors, lack of physical activity, high cholesterol, they're going to be at a risk even before menopause. Okay. And I just want to highlight one thing that I want to make sure I share with all the listeners. And it's the fact that heart disease is the number one killer in women, but it's also the number one killer in young women. And that is often missed. So heart disease is actually the number one cause of death of new moms. Remember, moms are in their 20s, 30s, and heart disease is the number one killer. And that is significantly worse in Black women and our minority women like Native women and Hispanic Latina women. So that's another important thing to highlight.
Why is that?
Well, why is it that we're seeing heart disease as the number one killer in new moms?
Yeah.
Yeah, so multiple reasons actually. Number one is that we've gotten really good about addressing all the other things that used to kill moms, like issues with bleeding and a lot of the complications post pregnancy. And now we actually are seeing a trend towards women getting pregnant older with all these other risk factors, right? They're getting pregnant maybe with some hypertension, diabetes, high cholesterol. And then we see more of these adverse pregnancy outcomes like preterm delivery, preeclampsia. So that's likely playing an important role into why we're seeing this increase.
Is it a combination of obesity and then also maybe some disparity in prenatal care?
Oh, absolutely. That also has a lot to do with it. Yes. We have a trend towards we're in this obesity pandemic, epidemic. And then with that, we see a rise of risk factors. And again, of course, some differences in prenatal care and care overall affects those rates.
Has cardiovascular disease always been the number one killer of women, or is this over the last 20, 30 years, has this become more of an issue?
No, sadly, that's been an issue for a very, very long time. It's just that there's not the recognition that it deserves. Unfortunately, if you ask a room full of women what the number one killer in women, many times you'll get people to incorrectly say it's cancer, particularly things like breast cancer. But no, heart disease has been and remains the number one killer in women. And unfortunately, we know from recent data that the knowledge of heart disease as the number one killer has actually gone down. So it's not that there's been a change in the reality of how it affects women. It's just that it's not recognized. And we're afraid that with the pandemic, that lack of knowledge is going to be even greater when it comes to recognizing heart disease in women and heart disease overall.
I'll get to COVID in a minute because I had a specific question from one of the listeners about COVID. In your mind, though, has research for women's cardiovascular issues been historically underfunded?
Yes, we know that we're significantly behind in our knowledge in cardiovascular disease in women for that very reason. If we don't do research specifically in women, then we don't understand diseases that may be more common. There's been actually a shift in funding so that women are studied more largely in NIH studies and studies overall. So that's where we're seeing this difference in increasing knowledge about heart disease in women, particularly in the last few decades.
Okay, you did mention that COVID has added another layer of complexity in treating women. Is it more than just people having put off their care?
So putting off the care was a huge problem, especially when we were in the lockdown. We know that we saw lower rates of presentations with things like heart attacks, and this happened in both men and women. That definitely affected the disease process, because if someone shows up on time with a heart attack, with a stroke, that we can intervene and the outcomes are much better than if they show up later with all the bad consequences like heart failure, etc. So that was a huge problem. And then, of course, we're still seeing the remnants of post-COVID syndrome. We're still seeing the pericarditis, which means inflammation around the sac of the heart, or inflammation of the heart called myocarditis at higher rates related to COVID. We're still seeing those cardiovascular effects. I actually just published a study in JSky where we look at myocardial infarction, so heart attacks, during the COVID-19 pandemic. And what we showed is that there were sex differences between men and women when it came to presenting with heart attacks during the COVID-19 pandemic. And in particular, what was very interesting is that although they did similarly, meaning the mortality was the same in men and women, what we found is that a lot more women had heart attacks. And when they looked for blockage in the large arteries, they didn't find blockage in the large arteries. And that's known as MINOCA, myocardial infarction with no obstructive coronary artery disease, which is actually one of the areas that I specialize in. And so that was very interesting. And that may be because COVID-19 causes a prothrombotic state, we believe, a lot of inflammation. And so patients were having more heart attacks. And then when you look for the type of blockage that we put a stent for, we didn't see that.
Oh gosh, this is really interesting because I'm thinking about someone I work with that is having the same issue. And okay, well, I know who I'm calling after we finish up here today. This was a specific COVID question. This listener asked about long COVID heart palpitations.
Mm-hmm.
She wants to know when those heart palpitations are considered serious and what you do and who should she see about these heart palpitations.
So we see a lot of palpitations as part of this post-COVID syndrome. We also see chest pain, shortness of breath. The shortness of breath could be both from a pulmonary perspective, from a cardiac, so that one's more hard to tease out. But yeah, in terms of palpitations, the natural history that I've seen with a lot of my patients and based on what's in the literature is that these get better over time. So initially, we do tell people more of like stay hydrated. Depending on the severity of these palpitations, you should see a cardiologist, possibly get a monitor so that we can assess the percentage of how many palpitations is that person having. And then depending on how it's affecting their quality of life and their other symptoms, we may consider suppressing them with medications for a short amount of time while they're bothersome, and then weaning off the medication as the post-COVID syndrome resolves. So that's what we've done with a lot of our patients. In terms of who to see, we have a lot of great cardiologists at Christ, and we've seen a lot of those patients even at our Women's Heart Center.
Okay. Another listener asked me, she said that her LDL, her bad cholesterol, hovers around 130. And her doctor wants her to get that down. But she's like, but my HDL, my good cholesterol, is always over 85 and sometimes gets close to 100. Is she really at increased risk for having LDL at 130? Should she see a cardiologist about this?
So before, there used to be the school of thought that if someone had a high HDL, there was some level of protection. But more and more data is coming out, which really shows us that LDL is a very good prognostic indicator, meaning the higher the LDL, the worse your risk. And so what the American Heart Association actually recommends us to do is to calculate an ASC, recommend statins and aspirin based on, what risk profile that person falls into. Well, that should be calculated in every patient. So if you want to know whether you should be on a statin for prevention or an aspirin, having your doctor calculate that ASCVD risk score is important, and it takes into account your lipid panel, okay? It takes into account the LDL and the HDL, so that really gives you an educated information on what your risk is and whether you should be taking something for prevention. Other tools that we should use to risk stratify patients, especially more for that intermediate group, again, the ASCVD risk score being really important first step, is whether a calcium score can help better risk stratify someone, because if there's calcium, and we find that out through a test called the calcium score, which looks at the calcium in all the heart arteries, and is a pretty small, not very expensive test that we do more for risk stratification. And so that could be helpful too, because if someone has positive calcium, then we take that into account, and usually we would recommend a statin in that person for prevention. Other things that we can do to better risk stratify would be a more in-depth lipid panel. Again, these are things that usually the primary care physician may be able to address, but if not, a preventive cardiologist can definitely help address those questions and risk stratify someone appropriately.
When you look at a more in-depth lipid profile, it looks beyond LDL, HDL, and triglycerides. It goes into a very dense LDL and that sort of thing. Is that what you're talking about?
Exactly. Yes, it does a deeper dive into the different lipid molecules and the ones that have been associated with a higher risk of coronary artery disease or cardiac disease.
Okay. Okay. You had mentioned something about calcium. What is the risk? What does calcium do to the coronary arteries?
So essentially what we're talking about is that when a plaque in a coronary artery stabilizes, it calcifies. So that's what that calcium score is doing, or what that calcium scan is doing, is it's looking to see if there's any evidence of stabilized plaque. And if there is, that has been shown to be associated with increased risk. And therefore, usually patients are recommended to be on a statin if they have an elevated calcium score. So that's what we're talking about.
Okay. We know what a lot of the risk factors are, and obesity, smoking. Can we talk a little bit about diet?
Yeah, so when it comes to diet, the diet that has the most data, which is the one that I recommend, is the Mediterranean diet and the DASH diet. So essentially, those have been studied in patients with cardiovascular disease and have actually shown to have improvements in outcomes. And therefore, that's what I recommend to all of my patients. A lot of greens, a lot of more olive oil as the primary oil, fruits and vegetables, nuts for snacks.
Okay. And you said the DASH diet. What does that entail?
So the DASH diet usually is done in combination with the Mediterranean, but the DASH diet is more focused on decreasing sodium intake, essentially.
Is sodium a bigger problem aside from hypertension?
So yeah, sodium has been linked definitely to higher levels of blood pressure, and that's a huge risk factor that if we can fix or correct will make a big difference in patients. But we also know that especially in patients with heart failure, that a diet low in sodium is particularly important, because when they have elevated sodium in their diet, they retain more fluid, they get volume overloaded. Some of them have exacerbations of our heart failure when they eat more salt. So we definitely have stricter restrictions for our heart failure patients.
I had a doctor recently tell me that I should get all red meat out of my diet. That would be really hard for me. Do you have a guideline for patients, like one day a week, anything?
Yeah, that one's tougher. I usually tell people you're not going to change your diet overnight. I mean, I have patients coming to me in their 40s, 50s. They've eaten what they've eaten for that long, and some of them are even older. So the reality is, people are not going to change their diet overnight just because the physician recommends it, right? Unless they had a big event and they really want to change their life and they're committed. The reality is, people are going to make ideally small changes that are permanent, right? And so I usually tell them, take a look at the Mediterranean diet, see how many of those healthy things you can incorporate into your diet. And if you just do a few, I am happy. If you eat less processed food, honestly, if you can cut down processed food, that's to me a lot more important than how many times you eat a steak. Because the reality is, all those processed canned foods and all these pre-prepared things have a lot of salt in it, and you don't know what they have in them. So the more vegetables someone can eat, the more fruits they can add into their diet, use olive oil. avocado. If they can incorporate that, how many times they eat meat is less of a negotiation.
Right. And I guess for some of those people too, I mean, you can give them a body mass index to shoot for, but do you see incremental gains? So if someone loses 8, 10 pounds or reduces their body mass index by a certain percentage, do you see a relative reduction in cardiovascular risk at that point?
The data on that is not as linear as you would think, because it's not just about BMI is really not a great assessment and we're stuck with it, but it doesn't really tell us anything about how our fat is distributed, whether it's visceral fat, which is the bad fat, or whether it's because of the muscles, right? Like if you're a bigger person and you're past your BMI because you're a muscular person, that's very different than if you're someone that just has a lot of visceral fat, okay? We need to look past BMI, and that's why I emphasize the importance on exercise and the importance on eating healthy and less of a only focusing on BMI. Of course, if someone's morbidly obese, that's different, right?
Right.
That we definitely want to help them with weight loss as a way of decreasing blood pressure, decreasing their sugar levels. I mean, weight loss is very important for a lot of the risk factors that lead to cardiovascular disease.
And I know back in the day, we would talk a lot about the difference between people that were more apple shaped versus more pear shaped. Is that because you tend to carry more visceral fat in the middle?
Exactly. That's what that's talking about. Where are people carrying their visceral fat and what kind of fat do they have?
Okay.
Is it the good fat or is it the bad fat? Yeah.
I don't want to be Mrs. Obvious here, but in terms of your own lifestyle, have you had to make some changes based on your research and how you live and eat?
Absolutely. Absolutely. I'm Cuban. So I was born in Cuba, raised in Miami. And if you know anything about Cuban cuisine, you would know that it has nothing to do with the Mediterranean diet and very to do with the healthy diet. A lot of carbs, a lot of meat. And so, yes, I had to make huge changes to my diet, and I'm very happy with that. As I learned, I realized I can eat that on the weekends, maybe, or when I go visit my family in Miami. But on my weekly life, I do adhere to what I preach to my patients. And I exercise too, because I make my patients exercise. So I definitely get on my Peloton every day, at least 5 days a week.
Great. And well, you practice what you preach, and I appreciate that very much. It's not like the old days when the doctor's telling his patients to quit smoking and he's got his Marlboros there, he's puffing away, but that's a long time ago.
Yeah,
And speaking of Miami and Cuban coffee, the best. I had the best Cuban coffee in Miami that I've ever had.
it is amazing.
It's phenomenal. We talked about prevention and diet and exercise, but I do want to talk about your groundbreaking study on women and the link between preeclampsia and cardiovascular disease, because you're doing some really great stuff at your center.
So I have an NIH, which is a National Institute of Health Career Development Award, to study and understand why women with preeclampsia, which is one of the hypertensive disorders of pregnancy, are at an increased risk of cardiovascular disease later in life. And there's new studies showing that not only are they a higher risk, but they're actually developing heart disease at an earlier age, like younger, like 40s, 50s. And so the goal is to understand, why is that? And one of the things that we're trying to determine is there evidence of little vessel disease that is, you're not going to be symptomatic from it, right, for many, many years, but is that happening in the background, and is that why women are at an increased risk? And microvascular disease or little vessel disease in the heart is one of my areas of expertise and of research. And so we are doing this study at the Lindner Center of Research here in Cincinnati. We are actively recruiting women who have had either a healthy pregnancy, because we really need healthy volunteers. Without the healthy volunteers, we don't have anything to compare it to. So we really are trying to get healthy volunteers who have had a pregnancy up to 10 years. So in the last 10 years, if they've had a pregnancy that was healthy, or of course, women with preeclampsia who had a pregnancy in the last 10 years, to really better understand, are there abnormalities that are essentially silent at this early stage that then we see later on. We do a stress cardiac MRI that's free of charge as part of the research study. So we get a lot more information of someone's cardiac function, and we even look for that little vessel disease. So that's my NIH research study. And then we have a lot of other exciting studies, again, related to women, and particularly in women with INOCA, which is ischemia with non-obstructive coronary artery disease. So this is something that I get very excited to share with listeners because I think is many times missed. And these are women, and also men actually, but more common in women, who have chest pain or a chest pain equivalent, meaning it could be shortness of breath when they exercise, it could be neck pain when they exercise, arm pain, predominantly on the left side, even nausea. So these women or men have these symptoms that make you concerned for blockage in the heart arteries, right? But then when they get either a stress test or even a look at their coronary arteries, they see that there's no significant blockage in the coronary arteries. And then a lot of times these patients are told that there's nothing wrong with them, that chest pain or those symptoms are in their head. And what a lot of them actually have is real angina, but they don't have obstructive disease, or they have even a positive stress test, but then a negative angiogram, and they're told it's a false positive. But those patients usually have ischemia with non-obstructive coronary disease. We are, number one, really trying to raise awareness that if you have symptoms that you know are real and no one has paid attention to you, we are recognizing these new syndromes called ANOCA and INOCA. We are part of this multi-center study called Warrior, which is a really cool name.
Yeah.
It's for women who have had these symptoms and don't have any obstructive disease. And what the study is trying to show is that if we treat these women more aggressively, number one, can we increase awareness? And number two, if we treat them more aggressively, can we decrease their risk of major adverse cardiovascular events down the road? Okay, because we think that these women are having these symptoms, they're being falsely reassured because they don't have obstructive disease, but a lot of them likely have underlying coronary microvascular disease, which is disease of the tiny little vessels in the heart that many people often don't think about. Okay, so that's a big plug for research, because that's how we can advance our knowledge and really learn how to treat women and also make a difference and change statistics, which it's about time that we do that together. And the Warrior study is funded by the Department of Defense, so that's really cool and very exciting. And then number two, it's a multi-center study, meaning that is throughout the entire country. There's a lot of centers that are part of the study. So if you're interested, it's very likely you'll be able to find this close to home.
That's great. And I think too, this is about education. And that's why I'm doing this podcast, because I want to educate women. First of all, I want them to be their own best advocate. I want them to get answers when someone poo-poos them about some pain in their arm. I'm like, no, 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 no. You go somewhere else. Just the fact that you brought this up about the preeclampsia and neck pain, arm pain, when you're exercising, some women may not take all those things seriously. And I think the other thing too, women tend to put themselves last. We're taking care of everyone else in our age now. Not only do we sometimes still have kids at home, sometimes we have adult men at home, which are like kids sometimes. And then sometimes we're caring for our aging parents. We just aren't necessarily paying attention to some of these warning signs and the little things, much less the self-care that I think is so incredibly important, that exercise and watching what we eat and just being good to ourselves. Any words about that? Like, what would you tell women right now in regards to their health?
Yeah, and thank you for bringing that point up, because I tell that to my patients. And actually, whenever I have the opportunity to have a platform, I always encourage, especially women, if you don't feel right, and I can tell you I've heard every single presenting symptom that you could imagine, from the jaw pain, and that's how they presented with a heart attack, to the extreme nausea all of a sudden. I've heard extreme fatigue. I mean, I've heard so many, and they were real. That was how they presented with their heart attack. And so I encourage, we didn't even get to talk about stroke, but stroke is a huge miss. Women are more likely to not have your typical stroke symptoms, and therefore they ignore it, and then they're having something as horrible as a stroke or as horrible as a heart attack. If you don't feel right, and it's enough to make you pause and get concerned and question, should I go get checked out? The answer is yes. Because with things like heart attacks and strokes, the sooner you get to a hospital and get evaluated and the heart attack or stroke is identified, the better the outcomes, the more you're likely going to go back to your old self. So yes, thank you for allowing me to bring up that point. And the other one that comes up a lot too is that if you do have a symptom and you have gone to a physician and you feel like they're not listening to you, then you need to advocate for yourself. And honestly, that's why at the Women's Heart Center, when we created it only less than 2 years ago, we felt strongly that we should allow women to self-refer, because many times women who are self-referring actually have that underlying microvascular dysfunction and have been told many times, no, that chest pain or whatever that symptom is, is in your head, and they know it isn't. And they finally found someone that listened and gave them a diagnosis, and a lot of them are getting better because we're treating them appropriately, right? The same thing, believe it or not, I didn't dive too much into it, but I did mention the whole thing about a heart attack without significant blockage. I can't tell you how many people come to us and they've had a real heart attack, and because they've had no blockage, they've been told, oh, don't worry, that was not a real heart attack. Yes, it was. It was a real heart attack. And we need to do additional testing so that we figure out why they had a different type of heart attack called MINOCA, myocardial infarction with no obstructive coronary artery disease. And the sooner they come to a specialist or someone that knows about this, the more chances we have to figure out the why they had that heart attack with no obstructive coronary artery disease. So yes, a big plug for advocating for yourself. If you know there's something wrong, keep looking for that specialist that will listen to your concerns and give you the right diagnosis.
Listen to your body and your intuition, because we have a gift for that. And I think we don't sometimes use it enough for ourselves. One last question, because I think this is one of the things that I had on my list, was any new treatments that are coming on the horizon?
So many new treatments. It just depends on what heart disease we're talking about. I mean, heart disease is a huge umbrella term for so many things, right? We have obstructive disease of the coronary arteries, heart failure. And the truth is there are always new treatments coming out. Just depends on which part of the heart we're talking about. But yes, and how it's possible? It's possible because we're doing research. Again, a big plug, because I think it ties to this, is we as women need to do research. If we're not part of the research studies, then we are not going to have a treatment that's specific for us, or we're not going to know about diseases that affect us more often. If you're approached about research, read it, educate yourself, but be open to it and be open to participating, because that's really the future for all of us.
I think those are great final words. And I do think that your message about prevention and taking care of yourself is equally important. So, Dr. Quesada, thank you so much for being here today. I'll make sure to put lots of stuff in the show notes, because I don't think anyone could write quickly enough to catch everything, but there were some great tips in here. So thank you so much.
Absolutely. And thank you for having me. I'm excited to hear the podcast.
Oh, yeah. I'll send you the link as soon as it's up.
Awesome.
Thank you. Have a wonderful weekend.
Thank you. You too.
Thanks. Follow Asking for a Friend on social media outlets and provide a review and share this show wherever you get your podcasts. Reviews and sharing help us grow.